morning, everybody, and welcome. We're here with Dr. Sita Hal. He's a urologist, and we're going to be talking about the new guidelines for prostate cancer screening. So, Dr. Sita Hal, prostate cancer for men worldwide versus the Caribbean. Is there a difference?
Yes, so prostate cancer is the second most common diagnosed cancer worldwide. Now, with the Caribbean, we have a higher incidence than a lot of the world.
Right.
And that has to do with genetic as well as racial changes in the world.
Okay.
We have seen that African men and men of African descent
Yes.
have an increased risk of prostate cancer.
Okay.
They also have an increased mortality risk with prostate cancer compared to East Indian men and Caucasian men. And we're just generalizing that. Yeah. Regarding specific islands in the Caribbean, Jamaica more than likely has the highest incidence.
Oh.
But remember, we're reporting on data that may be a little bit older.
Okay.
But they have about 163 per 100,000.
Okay.
Yeah. Whereas in Trinidad we have close to 70 per 100,000. So we have a little bit less. But that probably has to do with our changes in Africa versus East India.
Right.
Yeah, because for us, in our setting, 3 out of every 4 men will be an African male of African descent who is diagnosed with prostate cancer. And we just generalize in numbers as well.
Right.
Yeah, about 75% of men will be of African descent at diagnosis.
Okay. And do you think that these figures that you're presenting, one of the things that you're looking at is based on underreporting, or is it just that the numbers are not up to date?
So, underreporting and overreporting, to be quite honest, especially in Trinidad, where if you die, our death certificate says you died of a cardiovascular cause, and then they will list everything below.
Right.
And prostate cancer, if the man was diagnosed with prostate cancer, will go below, and then it may be reported as a prostate cancer associated death.
Ah,
Yeah.
okay.
So that part, time and a little bit of technology will help.
Right.
Because for at least in our setting, our reporting will simply just put prostate cancer and then move on.
Correct.
And then when we do our database search,
Yes.
they will flag prostate cancer and then it will be reported.
Ah,
Yeah.
understood.
Yeah,
Okay.
so whether it is that or not, but 4 to 5 men we think in all data will be diagnosed or will have some amount of prostate cancer at 80 years old. Yeah.
At 80.
At 80 years old. Now only 10% of these men are actually going to die from prostate cancer. So we tell our patients, you're going to die with prostate cancer, but not from prostate cancer. Yeah.
Can you explain that a little bit to our audience, please?
Yes. So when you are diagnosed with prostate cancer, and you don't even have to be diagnosed, you can not know that you have the cancer.
Yes.
Thankfully, a huge part of prostate cancers are very slow cancer.
Yes.
Yeah, more than 75% is non-aggressive prostate cancer.
Yes.
Now, what we don't want is for you guys to have symptoms of your prostate cancer and cause trouble to pass urine, pain in the back, pain in the bones, even fractures. I've seen guys up to last week who can't walk because they just didn't bother to screen for their prostate cancer.
Yes.
Yeah, and now has a fracture in their spine and
Paralyzed.
yeah, paralyzed for the rest of their life.
Yes.
So that's what we're trying to attack and decrease rather
Right.
than increasing how much we diagnose that doesn't need to be diagnosed.
Okay.
And that about 10 years ago created a huge problem in the States where it was thought, and it was that we were overdiagnosing prostate cancer across the world.
Okay.
And then they came off the blood test and they said, no, we're not going to be using the blood test. And
Right.
because of that, we saw a rapid rise in the mortality from prostate cancer.
Yes. Yes.
Yeah, so then we had to do a 180-degree turnaround and said, look, we're going to be using the blood test, but we're going to add things to the screening. For the
Okay.
prostate cancer.
So can you now just give me a little more information then? If it is that it was to use the blood test, not to use the blood test, what then were they using in place of the blood test
Right.
for screening?
So, 1980s, we had nothing. We had a rectal exam. Then the PSA blood test came about.
Right.
And the PSA blood test was shown that once it was high, it would correlate to a risk of having prostate cancer.
Right.
Now, the blood test isn't perfect at all.
Right.
On both sides of the coin, you can have a blood test that's normal, so anywhere from 3 to 4, and you still have a 25% chance of having cancer.
Right.
And 4 is what Trinidad considers as normal.
Cut off,
Yeah.
right, okay.
But we do realize that the PSA does go up with our prostate volume. So it's benign, but our prostate is larger.
Right.
And the PSA goes up, as well as age. So now we had adjuncts to PSAs and a lot of mathematicians running things, yes, to fix those things.
Yes.
And then in about 2015, give or take, MRI came about.
Yes.
And that has changed the screening pathway for prostate cancer now. So if you do your blood test and it's high, anywhere from 4 to 20, now you can access an MRI. And the MRI is able to tell us what is your risk of having aggressive prostate cancer.
Okay.
And then you move on to biopsy.
So the MRI must come before the biopsy?
No, it doesn't have to, but it will help to weed out the overdiagnosis part.
So I have now a very pertinent question.
Mm-hmm.
In the public system, we know that MRI is not the easiest thing to come by. So then how do we circumnavigate the fact that we have people who require testing, are unable to rapidly access the testing? How then do we overcome this?
Well, a good part is the prostate cancer will overcome it by being slow. So
Okay.
our wait time, while it may be a year,
Mm-hmm.
shouldn't really affect the cancer that much.
Right.
But secondly, at least for Eric Williams and Arena, I can't speak for both of those.
Yes.
We do about 10 to 15 MRIs per week for prostate specifically, at least,
okay.
And then we do at least 10 to 20 biopsies per week.
Oh,
Yeah,
that
so
is a significant amount.
yeah, so the wait time is a lot less than
So,
public system.
so the other RHAs,
Well, I would presume that they do, don't get me wrong, but I'm
The
not
time
liberty
is
to speak about them.
because you're not familiar.
Yeah,
Understood.
yeah.
Okay, no problem. Okay, thank you for that. Okay, so my next question then is, well, we talked about the current methods of screening.
Mhm.
We're working with what you just said is the current screening method.
Yes.
Okay, so then what is new in urology for prostate cancer screening?
Well, the finger test or the rectal exam, as men hate to hear it, that's gone, or that is going with time.
So it's being phased out?
Yes, so it's been shown that it does not help to diagnose prostate cancer in a setting that would allow for mass screening. And I'm being very careful with my words here, this.
Yes,
Right.
I've noticed that.
Yeah, because this is a bit of a controversial topic.
Yes.
Yes, some men will want their rectal exam, and we're not saying no. But prostate cancer's management has come to be something of shared decision making. And by that I mean, you get your screening based on speaking to your GP. Or
Okay.
a urologist, which generally is your family
Your GP,
doctor you're
correct.
speaking
Is
to.
the first line?
Yeah.
Yes.
And they tell you, look, this is what we want to do. If you want a rectal exam, or if you want your PSA, if you accept that when you do your PSA, that, and it's high, you accept an MRI or biopsy and those things. If you're not willing to accept that if your PSA is high, I'm going to move forward with testing and then treatment, then I'll tell you you're just wasting $250 to do a blood test. And well, all public systems, money, yeah.
Mm-hmm.
But the rectal exam by itself has not been shown to help in the diagnosis for mass screening of prostate cancer.
Right.
And the PSA alone as a screening tool, and then the adjunct to the PSA, which would be the MRI, if the PSA is between 4 to 20. Anything more than 20, we could just skip the biopsy directly.
Okay.
Yeah. And the MRI is only in men who have a normal kidney function test. If their kidney function is off, they can't have the contrast.
Right.
They guide the MRI, and then
Right.
they just move straight to biopsy.
Okay, so if you're allergic to contrast or have
Yeah.
poor kidney function,
Then we won't
they
be
just go
biopsy.
straight, you skip and
Yeah.
go straight to biopsy.
Yeah, and plenty of other things like claustrophobic and MRI. I don't know if you ever had one, but
No,
it's
but I've
not a
heard.
comfortable thing.
But
Yeah.
isn't there open MRI in Trinidad?
Yeah, Alexandra has an open MRI, and I want to say Kuva Hospital has one.
Cuba,
Yeah.
but it's not functional right now.
Yeah, but not functional or something like that.
Okay.
But they will be starting that. Yeah.
Mm-hmm. Okay. So now my next question to you then would be, has Trinidad adopted the approach of no digital rectal exam?
Right, so this was trashed out by the Caribbean Urology Association recently.
Okay.
Yeah, and they are going to start to adopt it. But the problem is there will be some more delay in when our guidelines come out.
Right.
So I would expect that the guideline would be adopted. How much would the guideline now trickle down to the urologist and then to the GPs? Well, a bit of that would be patient education.
Right.
Yeah, and physician education.
Yes,
Yeah,
of course.
because a GP will not be reading urology specifically, yeah. So
Mhm.
a bit of it would be that now the urologist will need to educate the GPs. And then I'm sure they will adopt it because it helps that the man now does not have to do
yes.
that. Yeah.
Yes.
Yeah. And now we
Yes.
could mass screen people quicker, blood tests
Correct.
faster,
Yes.
yeah, and get them sorted out.
Yes.
Yeah.
Because coming from a country that's heavily African descent based,
Yeah.
it has always been something that I've heard that men will legit not go to the doctor when they reach 40 because they hear that that is one of the main things that has to be done at 40 years old.
Yeah.
And they're like, no, I don't want that, so I'm not going to the doctor. And I know that's a massive barrier to screening. But then because you were speaking about over screening versus under screening,
Mm-hmm.
it does give a little bit of confusion.
Yeah. And the PSA is perfect at all, don't get me wrong.
Yes.
But at least it allows us something so we catch you guys earlier, because what we would like is curative prostate cancer. So you get cured either by surgery or by radiation and you walk away.
Yes.
I had this conversation just now with a patient and we went through his 3 options. And his option was what we call active surveillance, where we're just going to watch his prostate cancer for the next year.
Yes.
Every 3 months he comes to me. And then we biopsy him back in a year, and now he keeps his sexual function with his wife, doesn't have to undergo treatment, doesn't have the side effects of treatment, but at least he knows he has the ability for cure when or if he even wants cure now, because he's going home to speak with the wife and they're going to decide
Options.
if he wants to continue with surveillance or not. Yeah.
So you are now tapping into part of my purview as a physical
Mhm.
therapist, where you spoke about the sparing of sexual function.
Yeah.
And I know that sometimes that also is a barrier to men seeking treatment because they're deeply afraid that they will lose the ability to have an erection or a proper erection or a lasting erection if it is that they undergo prostate cancer treatment.
Mm-hmm.
So can you speak a little bit about the options of prostate cancer treatment where you spare the pelvic nerves,
Right.
therefore that they are able to maintain function?
Yeah, so surveillance. So that is we're going to watch, and this is probably the best one because then we're not actually going to be treating you unless we have to. So
Okay.
then the patient is able to retain their sexual function, whatever it was at the time.
Right.
The second would be a radical prostatectomy, and I probably should have spoken about it last because that has the most amount of risk. And it's not that it's any different to radiation. It's about 10 to 25% for both sides. The problem with a radical prostatectomy is that when you lose that nerve function, you lose it suddenly. It's an
Yes.
operation. Yeah, your nerves are either cut because of the operation or because the prostate cancer was on the nerves. It was difficult for us to push away the nerves.
Yes.
Yeah, and it's a bit of a psychological hit, man.
Yes, it is.
I was having sex the day before and
No,
now
I cannot.
I can't. Yeah.
Yes.
So that part bothers men.
Yes.
Now the radiation treatment, you're still gonna have that erectile dysfunction, but not then.
Severe.
Yeah, you're gonna have it 10 years after, and at 10 years it probably is the same. Now, the mean time when we diagnose prostate cancer is about 72 years old.
Okay.
So if at 82, I'm going to tell my guys, well, back up, look, you're not going to be able to do it, but at least you reached the 82, you know it?
I think that will cause a little bit of disturbance, Dr. Sita.
I know, but as men,
Because
I
people,
want-
I think, pause, just one second.
Sorry,
I forgot
sorry.
you.
Yeah.
But I think that a lot of people, and especially given to my profession and the amount of time we spend with our patients, especially males, more so than females, but males for sure, they do tend to want to maintain that. And I think that men in general, no matter their age, they find sexual function to be a massive part of their identity.
Mhm.
I guess some people link it, and don't castrate me for this, but a lot of women when you take their breasts,
Yeah.
they
I was
feel
going to
like
bring
if
that, yeah.
you have taken who they are essentially as a woman,
Yeah.
and men by extension feel the same way when they cannot get an erection as a man. And it doesn't matter if they are a teenager, if they're in the 20s, all the way up to if they're 90 something. You know, we do hear of the odd man who in their 80s has fathered a child.
I have a couple of patients.
So,
Yeah.
you know, so
Yeah.
yeah. But how can, I know that there are non-invasive ways of treating this, but do you, when you tell them that they are at risk of losing their pelvic nerves and therefore erectile function, do you then discuss with them the options of getting an erection or maintaining an erection?
So yes, we do discuss those options, but those options, this sounds very hard to demand. Our first goal is to make sure your prostate cancer is treated, especially if it's aggressive prostate cancer.
Of
If
course.
it's non-aggressive, I tell them, look, we have choices. And brachy, which is the last one that we
Yes.
didn't really touch on.
Yes.
Brachytherapy is where we put those radiation seeds in.
Yes.
That's the best option for preservation of erectile function. But you have to have non-aggressive or early prostate cancer.
Okay.
Yeah. And with modern technology advancing, we will have brachy being available to more aggressive cancers later on. Yeah.
Okay.
So what we do in Trinidad is low dose brachytherapy. Currently in the States you get high dose and then you could do more aggressive cancers. Yeah. So then those guys would have preservation of their erectile function a lot more.
Right.
But we were speaking about the open surgery and the laparoscopic surgery that we allow in Trinidad, or that we do in Trinidad. Robotics does have a decreased risk of erectile dysfunction to an open surgery.
Of
Yeah.
course.
So if our patients can afford, there is a huge amount of patients who go up to Miami and have robotic surgery and come back. Yeah, and pretty soon, I know a couple of hospitals in Trinidad are looking to bring in a surgical robot. And then within the next few years, we're going to see that technology come about. Yeah.
Okay. Well,
So
that's
guys
very
will have a
exciting.
decreased risk. Yeah.
Yes.
But to come back to your point, yes, so we do need to take care of penile health and erectile function. Before they go for the operation, they start the Kegels, they start all those exercises for incontinence. And then when they're finished, then we start back the
Yes.
pelvic floor physiotherapy. Yeah.
Mhm.
Unfortunately, for most of our guys, we don't actually send them to physio as often as they should go to physio.
That is correct.
Yeah.
Yes.
Because they really should have preoperative physiotherapy
That
and
is correct.
erectile
To help
function.
you.
Yeah,
Correct.
and then we institute post-op.
Yes.
But for some reason we haven't we didn't reach there yet. Yeah.
Well, hopefully this will be a step in the right direction.
Yeah.
Okay. And so my final question to you is, are there any barriers that limit local implementation and how can we overcome them? So local implementation, well, you spoke about it in terms of the Caribbean urologist discussing the new guidelines, but do you anticipate, other than the fact of the trickle-down effect of the knowledge being out there and it trickling down to the GPs and thereby the patients, patient education, but do you foresee that there will be any further barriers to us getting the word out there that patients will be able to say to their doctor, hey, I don't want the digital rectal examination, I want you to do the blood test, and them having the blood test and then taking it from there? Do you anticipate that there will be any further issues?
Hopefully not, but historically doctors are a blood complex.
That is
Especially in
correct.
Trinidad, yeah.
Thank you for recognizing
Yeah,
that.
and it has changed, I would think, or I would hope, at least for the younger specialists and GPs for that matter. And there's no bash on the older guys.
Of
But
course, understood.
yeah, but the thought that a patient could say no to a procedure, yeah, that was frowned upon before. Now
Yes.
patients have choice, and they have choice of not just what they want to do, but by
Who
who
they
they want to
want
go to. Yeah.
Correct.
Yeah,
Yes.
so I
Yes.
think it's going to change because if the urologists or the GPs are going to stick to that type of mentality, patients are just going to leave you and go to
Somebody
what they
else.
want.
Correct.
Because now education is literally out there. I mean, how
Yes.
many people are going to see this?
Yes.
Yeah.
Yes.
So they're going to say, well, look, I do not want to go to that person. Yeah.
Yes.
And I think that will be a barrier.
Right.
I don't think it will be hopefully not a barrier that's going to stay for very long.
Okay.
Yeah. And even the older heads, most of them are mendable to change.
Mhm.
They are going to be the guys who,
Yes. Yes.
stubborn and stuck in their ways. But all men are stubborn and That's what we do.
No comment, I'm a female. So my last one to you is insurance companies.
Mhm.
So you know how insurance companies like to see things a certain way based on guidelines, and if you skip a step, they tend to give a little bit of trouble to pay.
Mhm.
Do you anticipate that with these new guidelines, though issues with disseminating how it's passed on, but do you anticipate patients will have issues with insurance companies?
No, I would hope not. And most insurance companies won't have a problem with such a small rectal exam issue.
Okay.
It's when the treatment side comes, that's when they start to
Jump.
ask more questions. Yeah,
Right.
because that's when the money comes into play.
Of course.
And at the end of the day, it is a business, so yeah.
Okay.
I don't expect insurance companies to have any issue, yeah.
Okay, I was just asking because I know a lot of patients complain that they can't get reimbursement for MRIs, and you did say that that was a salient part of diagnostics. So,
A huge part of the problem with MRI is the cost of an MRI.
Yes, of course.
So it's going to be generally about $4,000 to $4,500, and that's quite high for
That's significant,
a
yes.
significant portion of the population. The UK now is going to start a huge trial, £42 million, to PSA and then MRI those men. And when that trial results come out, it may push for MRI to get cheaper and cheaper, because then
more commonplace.
yeah, more commonplace. And
Okay.
then, yeah, once the ability for more MRI machines, then we'll have a little competition and yeah,
Of course.
things will get cheaper.
Of course, yeah, supply demand.
Yeah, yeah.
Yes, okay, got you, okay.
Yeah.
Thank you very much,
No
Dr.
problem.
Sita Hall, I really appreciate you coming today.
No problem.
Okay.